Now, let's learn about diagnosis stewardship in skin and soft tissue infections. Skin and soft tissue infection result from microbial invasion of the skin and its supporting structures. The management is determined by the severity and location of the infection and by patient comorbidities. Most common acquired infections are caused by methicillin-resistant Staphylococcus aureus and beta-hemolytic Streptococcus. Simple infections are usually monomicrobial and present with localized clinical findings. In contrast, complicated infections can be mono or polymicrobial and may present with systemic inflammatory response syndrome. Diagnosis is based on clinical evaluation. Lab testing may be required to confirm uncertain diagnosis, evaluate for deep infections or sepsis, and determine the need for inpatient care. Evaluate and treat the comorbidities. Initially, antimicrobial choice is empiric, and in simple infections should be covering Staphylococcus and Streptococcus species. Patients with complicated infections, including suspected necrotic fasciitis and gangrene, require empirical polymicrobial antibiotic coverage, inpatient treatment, and surgical consultation for debridement. What are the types of skin and soft tissue infections? One is wounds, which can be open or closed. Then there are abscesses, where we see pus under pressure. Then we see bullae, a bubble-like cavity filled with air or fluid. Then we see cellulitis, where is inflammation of the subcutaneous connective tissue. Then we see vesicles, a fluid-filled or air-filled cavity or sac. Then we have sinus tract, where there is a narrow opening or a passageway. These are the examples. These are the pictures of erysipelas, cellulitis, and necrotic fasciitis. You see, the erysipelas is a reddened inflamed area on the skin, whereas cellulitis is most grievous with edematous appearance. By necrotic fasciitis, we see uh, sacs filled with pus and fluid. The diagnosis of skin and soft tissue infection is predominantly clinical. A complete blood count, a C-reactive protein, and liver and kidney function should be ordered for patients with severe infections and for those with comorbidities causing organ disinfection. Blood cultures are unlikely to change the management in otherwise healthy immunocompetent patients and are typically unnecessary. However, because of the potential for a deep tissue involvement, cultures are useful in patients with severe infections or sign of systemic involvement in order in older or immunocompromised patients and in patients requiring surgery. Wound cultures are not indicated in most healthy patients, including those with suspected MRSA infection but are useful in immunocompromised patients and those with significant cellulitis, lymphangitis, sepsis, recurrent persistent or large abscesses or infections from human or animal bites. What should be the diagnostic approach for skin and soft tissue infections? It can be mild localized superficial lesions where there is no need to investigate. If it is a moderate with systemic features, wherein we see fever and large lymph nodes and systemic features, then do gram stain culture and blood cultures. Immunocompromised, then failure to response, the culture is required. Severe SSI, STI with systemic features, then wherein we see high grade fever, low body temperature, cold, pale extremities, respiratory is high, WBC count is high, little or no urine, then do the gram stain and culture and sensitivity, especially blood cultures will be required. These are the pictures of furuncles, then we see carbuncles, then abscesses and impetigo. Furuncle we see a single hair follicle involved where there is a clusters of hair follicles involved in carbuncle, and abscess is a pus-filled cavity, while named impetigo similar vesicles are seen in and around the lesion, parts of mouth. Then diagnostic approaches for purulent skin soft tissue infections. If it is mild, localized, then do incision and drainage. If it is moderate, incision drainage. Then if no response, culture sensitivity and blood cultures. If it is serious with high grade fever, endotoxin shock, do gram staining and culture sensitivity. Now, what is the diagnostic approach in case of fungal skin soft tissue infections? If it is superficial mycosis, skin, hair, nail, mucous members are involved. Do no testing. 10% KOH will be required. Clinical management will do. Subcutaneous mycosis where subcutaneous tissues are involved, then microscopy, histopathology and cultures will be required. If it is systemic mycosis in immunocompetent and immunocompromised, then blood cultures will be required. Regarding skin and soft tissue infections, what will be specimen collection? Presence of squamous epithelial cells, not in neutrophils on gram stain is associated with a superficial specimen. Swabs is not preferred specimen, avoid as much as possible. Swabs are not acceptable for anaerobes, mycobacteria, perirectal abscesses, oral abscesses, and fungal skin infections. Use Dacron or Raven swabs not cotton flock swabs. Swabbed viable wound tissue, not dead or dying neck tissue or pus. Swabs of sinus tract or cellulitis give very poor yield. Tissue biopsy will be done from the advanced marginal lesions. Needle aspiration is preferred, then bullae, vesicles, fresh, closed wounds, undernapsis, and sinus tracts. Can refer to the sample collection in the article by Metley et al. In the Journal of Critical Medicine. How does a specimen will be transported? If it is swabbed, then transport immediately. If not possible, use the transport medium. Transport medium can be added towards medium and mixed medium. If there is a delay, then refer it to swab. Aspirate should be kept in a sterile container and should be delivered immediately within 1 hour. To maximize the isolation of anaerobe, transfer 10 ml of 5 to 10 ml of aspirated material into an anaerobic transport vial. If requested for apiculture, then transfer at least 1 ml of the aspirated material into sterile container. Swabs, however, should not be acceptable for microscopy or culture for mycobacteria. Regarding transport, place the specimen in a sterile container or a sterile gauze moistened with sterile non-bacteriostatic saline. Transport in less than an hour. Send in an anaerobic transport medium for isolation of anaerobic organisms. Do not submit the tissue in formal. That was about skin and soft tissue infection. Let us see about genital infection. Genital infection can be localized infections or systemic, which can be either genital ulcer, discharge, or pelvic inflammatory disease or others. Genital ulcer could be because of syphilis, where is chancre or chancroid or herpes, or lymphogranulovenerum or granuloma inguinale. The discharge may be because of from urethra, vagina, and cervicitis. In case of urethra, the causes are gonococcal and non-gonococcal. In case of vaginosis, it can be because of candidiasis, trichomoniasis, bacterial vaginosis, gonococcal and non-gonococcal again. It is very essential to understand the etiology. We can refer to the articles for guidance for the management of symptomatic sexually transmitted infections in the Geneva World Health Organization 2021 publications. What's the diagnostic approach for genital tract infections? Clinical syndromic approach is required when we require the physical examination, clinical signs and symptoms assessment, and risk assessment. Point of care immunochromatographic tests are available for Neisseria gonorrhea, Chlamydia trachomatis, and Trichomonas. Microscopy should be done using a weight mount or a gram stain for diagnosis of Trichomonas, Candida, and bacterial vaginosis. Molecular assays are available for diagnosis of Neisseria gonorrhea, Chlamydia, Trichomonas. Offer HIV and syphilis tests based on its risk assessment. Guidelines for the management of symptomatic STDs are available in the WHO guidelines publication of 2021. Let's see about sterile body fluids. Sterile body fluids include sample collection from percutaneous aspiration, from pleural or pericardial or peritoneal or amniotic and synovial fluids. Usual asepsis during sample collection. Inoculate directly the sample into the aerobic and anaerobic blood culture bottles up to 8 to 10 ml in each. Alternatively, inoculate blood culture bottles after receipt of sample into blood laboratory. Generally, the samples are very inadequate in such cases. Good samples are essential for good results. That's a take-home message from this session. We'll see in details about the skin and soft tissue infection in the next session. Thank you.